The following podcast is part of a certified educational activity titled The Latest Evidence on Treatment for Uncontrolled Persistent Anemia. Breaking news from Dallas. Access the entire activity and complete the post-test at peerview.com/GSV860. Downloadable slides and practice aids are also available.
Hello, I'm Dr. Monica Kraft from the University of Arizona Health Sciences. Welcome to this educational activity on emerging data on treatment of uncontrolled persistent asthma presented at the 2019 American Thoracic Society International Conference held in Dallas, Texas. So today we're going to be talking about asthma, and we know a significant number of patients with asthma are not controlled with the inhaled medications we have available to them. Many of these patients become dependent on oral steroids, which can be associated with serious side effects when used long-term. Targeted biologic therapies may allow these patients to achieve asthma control and limit their use of oral steroids. Biomarkers are also particularly useful in uncontrolled asthma in defining endotypes and predicting response to therapy. So options for targeted asthma treatments have recently expanded and will continue to expand in light of the numerous therapies in development. We're going to start with the anti-IL-5 therapies, and they've been shown to improve lung function, asthma control, quality of life, and are associated with reductions in exacerbations, symptoms, and oral steroid use. The data for the anti-IL-5 therapies, which include Mepolizumab, Reslizumab, and Benralizumab, were presented at ATS this year. All three biologics have been approved for add-on maintenance treatment of patients with severe asthma with an eosinophilic phenotype. Mepolizumab and Benralizumab in patients 12 years of age and older, Reslizumab for those patients who are 18 and older. So let's take a look at some of the post-hoc analyses that have been done looking at Mepolizumab in patients with severe eosinophilic asthma. This meta-analysis of two phase 3 trials, the MUSCA and the MENZA, assessed the effect of Mepolizumab in patients with severe eosinophilic asthma really stratified by age of asthma onset. There's a perception that the anti-IL-5 biologics are more effective in those patients whose asthma presented later in life. So this abstract was really trying to take a look at this. And in this analysis, the patients were at least 12 years of age and had to have had at least 2 exacerbations in the previous 12 months, despite using high-dose inhaled corticosteroids. They all received 100 milligrams sub-Q or placebo, but for 24 weeks in the MUSCA trial or 32 weeks in the MENZA trial. 935 patients were analyzed. And what's interesting is in both age at onset categories, Mepolizumab significantly reduced clinically significant exacerbations versus placebo. So it didn't matter when the asthma presented itself. And I think these graphs show that. In addition, these data really show the rate of exacerbations requiring emergency department visits and hospitalizations, obviously 2 outcomes we care about very much. They were reduced in both age at onset categories. However, the effect was more pronounced in those patients whose asthma presented earlier in life, so a little contradictory to what the perception is. Looking at baseline FEV1, the improvements in lung function were actually greater than placebo in both age at onset categories. So the bottom line is that age of onset of asthma really did not seem to predict the effect of Mepolizumab. So that I find these data quite helpful. Lastly, the St. George's Respiratory Score and asthma control were also improved in both groups, regardless of age of onset. Let's move to another meta-analysis from the same 2 trials, the MENZA and the MUSCA. We're really looking at asthma control. Because again, I think we have been focusing a lot on exacerbation improvements, which of course we want to see with biologics, but what about some of the other asthma outcomes that we care about? So in these patients, in this analysis, 69% of all patients had uncontrolled asthma. And there was benefit on asthma control with Mepolizumab. About 49% of patients received at least partial or complete asthma control at the end of treatment, which is quite remarkable. However, it is important to note that 30% of the placebo patients did too. So that's why it's important to always have a placebo group. However, the effect was more remarkable in Mepolizumab. And this clinically significant and persistent improvement was observed after 3 doses at 12 weeks. So it took a little while to see that effect. And I think that is very helpful for those of us who use this biologic when to expect to see that change. Now we're going to switch gears and talk about Benralizumab, which is an IL-5 receptor inhibitor. And this is a retrospective analysis looking at oral corticosteroid-dependent patients who were on at least 7.5 milligrams of prednisone a day, despite receiving Mepolizumab for 6 months. They were then switched to Benralizumab at 30 milligrams sub-Q. Now, this is a small study, so we have to take that into consideration. However, I think it was still very interesting because we don't have head-to-head studies really looking at biologics compared to each other. So this switch from one to another is at least a way to try to understand the differences in response rates. And what these data show was the median oral corticosteroid use at the final injection of Mepolizumab was 10 milligrams, compared to 7.5 after 16 weeks of Benralizumab. So a slight improvement with Benralizumab. If you stratify the data and look at it a little bit more granularly, 2 of the patients were able to completely discontinue oral corticosteroids altogether, which I think is quite remarkable. And 7 patients achieved at least a 50% reduction in oral corticosteroid dose. So I think that is also nice to see. And remember, this was after receiving Mepolizumab. There was no significant improvement in asthma control. There was an improvement, however, in quality of life. And again, no significant change in exhaled nitric oxide or lung function. So I think the take-home message is that there may be some patients who do not completely respond to one IL-5 inhibitor and may do better on another. I think we do need more data to really understand who those patients would be that we would consider for that change. All right, I'd like to also talk a little bit about an efficacy and safety analysis, and this is through 2 years in patients treated with Benralizumab. So these were ongoing safety analyses done from the phase 3 trials, Sirocco and Colima, as well as Zonda, which is the study where patients who were oral corticosteroid dependent participated. They all moved into what's called the BORA study, which is ongoing long-term safety and efficacy trial. And these patients all were on medium or high dose inhaled corticosteroids and long-acting beta agonists, as we would expect. And then they received the Benralizumab 30 milligrams every 4 weeks for the first 3 doses, and then every 8 weeks thereafter. So looking at some of the outcomes, it looked as though the effect was sustained over the 2-year period when the patients moved into the safety and efficacy study. So the mean Benralizumab exposure was 24.2 and 24.7 months, respectively. And the reduction in exacerbation frequency that were seen in the phase 3 Sirocco-Colima studies were maintained, as well as the improvements in lung function and asthma control. So that's very encouraging and I think comforting to know. Improvements in the oral corticosteroid reductions that were seen in Zonda were also maintained. And the rates of adverse events really didn't change during the BORA study. So this says to me that, in fact, we now have more experience with this IL-5 inhibitor, and we can see that the effects that we expect to see, improvements in exacerbations and lung function and asthma control, are sustained, as are improvements in oral corticosteroid reduction. This is a post-hoc analysis of 2 randomized 52-week placebo-controlled phase 3 trials of Reslizumab. Remember, this is the IV form of an IL-5 inhibitor. So this is the ligand inhibitor, given 3 milligram per kilogram IV. So it's a weight-based dosing. So that's how it really differentiates itself from Benralizumab and Mepolizumab. However, it is an IV infusion. So these patients, as you would expect, were the GINA 4-5, which means they were severe and had to have had at least 2 exacerbations. And in this case, the blood eosinophil counts were a bit higher. They were at least 400 per microliter. And the trials included 953 patients, about half on Reslizumab, half on placebo. I think what you can appreciate that a higher proportion of patients receiving Reslizumab had no exacerbations. So 61% had no exacerbations versus 30% in placebo. Again, always important to look at that placebo, but I think the difference is significant. And Reslizumab also increased the time to the first exacerbation, 18 weeks versus 4.6. I think that is also very significant. So I think Reslizumab has a place in our armamentarium. I think that we have a little bit more in the way of hurdles to overcome because of the IV formulation, but it certainly has efficacy, especially in those patients with high eosinophil counts. And then a higher proportion of patients receiving Reslizumab had improvement in baseline FEV1 of at least 100 milliliters, which we consider significant at week 52. Now you'll notice the placebo group also had an improvement, but I think the difference is relevant. Now, looking at outcomes such as systemic corticosteroid use and asthma control, the proportion of patients requiring no systemic steroids was higher in Reslizumab versus placebo, and that goes along with the exacerbation issue as well, 61% versus 30%. And also a higher proportion of those patients who received Reslizumab had significant improvements in their asthma control. And this was 81 versus 63%, and asthma-related quality of life. So Reslizumab has effects on a lot of different asthma domains, clearly in exacerbations, but also lung function, use of oral steroids, and asthma-related quality of life and asthma control. So really important domains of asthma. This study is the IDEAL study, and this is a post-hoc analysis of a real-world study that really looks at how many patients are treated with which biologics as of mid-2018. So now for this study, 4 biologics were evaluated. There are about 669 patients who met criteria. And so I'll show you data in the overall cohort, and in particular those who had at least one exacerbation in the previous year, because that would be the group that we would consider certainly most strongly for biologic therapy. And this is assuming high-dose inhaled corticosteroid long-acting beta agonist as baseline. So you can see these 2 figures, and figure 1 really looks at the entire cohort. Figure 2 focuses more on that group who had exacerbations, so I'd like you to look at that. And you can see the 4 biologics that were evaluated would be Mepolizumab, Benralizumab, Omalizumab, and Reslizumab. You'll notice about 23 of the patients of the total cohort were eligible for all 4, and 11 were eligible for 3 of the 4. So I think I find this study interesting as we have a lot of choices for biologics now. Several of the eligibility criteria are quite similar, so how do we make the choice? And we have a lot of ongoing discussions about how to do that. And this study just really verifies that, in fact, all the biologics are being used, and I would be actually particularly interested on how the choices were made in a little more granular fashion, so hopefully we'll hear more about that in the future. All right, I'd like to talk a bit about Dupilumab, which is an anti-IL-4 receptor alpha inhibitor. So it inhibits both IL-4 and 13, which are 2 key mediators in type 2 inflammation in asthma. It was approved in October 2018 as add-on treatment for patients with moderate to severe asthma, so not just severe, but moderate to severe, 12 and over, with an eosinophilic phenotype, or those patients who are on oral corticosteroids. There were several studies presented in Dallas on the use of Dupilumab and some of the outcomes that we care about, as well as its use in chronic rhinosinusitis and nasal polyps, which we see frequently associated with asthma and can be a very challenging problem to address. So I'd like to present some of those data to you. So this is a pre-specified analysis from phase 3 Liberty Asthma Venture Study. So this in particular is looking at asthma control and health-related quality of life. And as I was talking about earlier, the focus for the phase 3 trials have been mainly on exacerbations, perhaps lung function, less so on some of these other asthma outcomes. So now these post-hoc analyses are being done to really address these areas, which for the patient, of course, are probably going to be 2 of the most important areas. So in this study, patients received Dupilumab or placebo, and they had a significant ACQ scores, as you can see, 2.42 and 2.58 in the treatment and placebo group, suggesting asthma that was not well controlled, and quality of life scores that also suggested a significant impact of their asthma on their quality of life. So what the data showed is in the Dupilumab group, asthma control rapidly improved, and this is interesting, by week 2, with a significant change of 0.57, which is a clinically significant change for the ACQ score, and further improved at week 12 with a 1.01 change. Again, another significant change in that score, and then remained stable on after that through week 24. And there was also an improvement in the asthma quality of life score, seen initially at week 12, and then further improved at week 24. So quality of life continued to improve throughout treatment, and asthma control improved very rapidly and also continued for at least 12 weeks. And the adverse events in the placebo group versus treatment, we have to remember that Dupilumab can cause some eosinophilia, so just something to be aware of, and injection site reactions were similar. All right, so in this study, looking at, again, the phase 3 analysis of a Dupilumab study, in this case the Liberty Asthma Quest, was looking at patients who had later onset asthma, so those who were whose asthma presented after age 40, and stratified by lung function. In this case, they looked at FEV1 FVC ratio of less than or equal to or greater than 0.7, trying to get at cohorts with and without fixed airflow obstruction. And does that somehow impact the effect of Dupilumab? So patients received either 200 or 300 milligrams every 2 weeks versus placebo. And the good news is that improvement in exacerbation rates occurred in both groups, regardless of whether fixed airway obstruction was present or not. However, when the data were looked at with regards to the pre and post bronchodilator FEV1 and the ratio, it improved in the Dupilumab treated group who had this late onset asthma, who also had the fixed airway obstruction. The late asthma onset patients who didn't have the fixed airway obstruction had more modest improvements in their pre-bronchodilator FEV1. And perhaps the group with the fixed airflow obstruction had greater improvements to be seen. They may have had a lower FEV1 to start with, or there may be more benefit from Dupilumab in patients with lower lung function. However, it certainly looked like both groups benefited. This post hoc analysis, this was really looking at lung function and by number of exacerbations. So if a patient had multiple exacerbations, would they have a greater improvement in their lung function, or did that matter? And so this post hoc analysis looked at patients who received either 200 or 300 milligrams of Dupilumab every 2 weeks. And in fact, the data show that regardless of the number of baseline exacerbations these patients had, which were either 1, 2, or greater than or equal to 3 in the previous year, lung function improved similarly. So the number of exacerbations didn't seem to impact the improvement in lung function. Everybody improved. So that's good. That's actually good news. Now switching gears to the upper airway, because of course this can be a very challenging area to address, especially patients who have nasal polyps. And so this is a study looking specifically at improvements in upper airway outcomes, but also a good percentage of these patients had asthma, so lower airway outcomes were also evaluated. And so this is a post hoc analysis from 2 trials, Sinus24 and Sinus52 phase 3 studies, looking at the effect of Dupilumab versus placebo on a background of mometasone nasal spray. And so the cohorts from each of the studies that received Dupilumab 300 milligrams every 2 weeks were evaluated. And I think what I find quite interesting is that as improvements in both upper and lower airway outcomes were seen. Of the 724 patients, 59% had comorbid asthma. So not surprising that asthma and sinus disease, especially those with nasal polyps, really travel in the same circles. So a very significant proportion had asthma. And as you can see from the outcomes, FEV1 improved by over 200 mils, which is significant. The ACQ, so asthma control, also got better. And then the upper airway outcomes, which included a SNOT-22 questionnaire, the nasal peak inspiratory flow rate, the endoscopic nasal polyp score, patient-reported nasal congestion, and the sinus Lund-Mackey CT score also improved. So I find these data very helpful in that Dupilumab actually has effects independently on the upper airway as well as the lower airway. And I think for those of us, we treat patients, it's one big airway, and I'm happy to see that Dupilumab has effects in both arenas. Switching gears to talk a bit about Tezepelumab, which is a biologic under investigation for uncontrolled asthma, and it's an inhibitor of TSLP, or thymic stromal lymphopoietin, which is an airway epithelial cell product. It regulates type 2 immune responses by activating dendritic cells, innate lymphoid C2 cells, and B cells. Tezepelumab has completed phase 2 study and is now in phase 3. And it's received breakthrough therapy designation from the FDA for patients with severe asthma without an eosinophilic phenotype. That is particularly interesting, as for those of us who care for these patients, we know that treatment options are limited for non-type 2 asthma. So that's very exciting. And there were a few abstracts presented at ATS on Tezepelumab that I'd like to tell you about. So this looked at the impact of Tezepelumab on hospitalization and emergency department visits in patients with severe uncontrolled asthma. And this is looking at the Pathway phase 2 trial. And obviously, hospitalizations, emergency department visits, and ICU visits for asthma, obviously outcomes we want to avoid. So how effective was Tezepelumab in each of these domains? So these were patients aged 18 to 75 years who had uncontrolled asthma, despite treatment with medium or high dose inhaled corticosteroids and a long-acting beta agonist. And they received one of several different doses depending on the randomization. They could either get 70 milligrams every 4 weeks, 210 milligrams every 4 weeks, 280 every 2 weeks, or placebo. And there were 550 patients who were randomized and analyzed. So Tezepelumab had a significant impact on hospitalizations, and as you can see in the figure, and really significant regardless of the dose of Tezepelumab. So there are the 3 doses listed there, as well as a pooled group at the end. I think these data are quite compelling in that suggesting that regardless of the dose received, that asthma exacerbations requiring hospitalizations were improved. In addition, Tezepelumab also had benefit in all-cause hospital and ED visits compared to placebo. And you can see the data there. Really most significant in the pooled analysis, and a couple of the doses of Tezepelumab also showed significant benefit. But I think this is a very interesting set of outcomes in that all-cause hospitalization and ED visits obviously are very important to our patients, and Tezepelumab had an impact on both outcomes. Now, thinking about Tezepelumab and biomarkers, we're talking about whether its effects are there in type 2 asthma, non-type 2 asthma, and how do biomarkers predict the response. And again, so these are post hoc, and we'll be getting more information about this certainly from the phase 3 trial, because the phase 3 trial is actually looking at type 2 asthma and non-type 2 asthma in a larger cohort, so that will be very instructive. So for this study, this was looking at patients' response to Tezepelumab and how baseline biomarkers predicted that response. And the biomarkers that were looked at were exhaled nitric oxide, blood eosinophils, blood interleukin-5, interleukin-13 levels, IgE, periostin, which is IL-13-driven biomarker, used less these days, not really available for clinical use, and then TARC, another type 2 biomarker. I think this figure really says it all, that these are all the biomarkers stratified into quartiles. And I think what you can appreciate is regardless of whatever biomarker was present, at whatever level, Tezepelumab had benefit. So I think this just confirms, or at least supports, the concept that Tezepelumab has significant impact in type 2 and non-type 2 asthma. It's always important to remember these are post hoc analyses, and we really are waiting for the phase 3 data to confirm all that we're seeing. But certainly this looks very encouraging. So as I mentioned, biomarkers, of course, are becoming increasingly useful, and I use them in my own practice. And so let's take a look at some of the studies where biomarkers were presented at ATS. So this is kind of a new biomarker looking at interleukin-6 and interleukin-6 receptor levels. And where did this come from? Well, there is a hypothesis that elevated IL-6 levels are associated with a phenotype of asthma that is associated with obesity and metabolic syndrome. And so is that true? And so the Severe Asthma Research Program, or SARP, looked at this in their cohort. And so they looked at serum IL-6 levels, which they had available, and found that the higher levels were correlated with an older age, with asthmatics that were older, were female gender, and had a higher BMI. So in support of the hypothesis that maybe this is a particular phenotype of asthma. However, when the data were adjusted for these variables, age, gender, and BMI, higher IL-6 levels still correlated with low lung function, higher blood neutrophil counts, and asthma hospitalizations, as well as systemic corticosteroid use. So there may be more to the story in terms of how IL-6 impacts asthma. Interestingly, the receptor levels really didn't correlate with any of these phenotypes. And so the bottom line is serum IL-6 levels could be considered as a biomarker, and I think we still maybe need a better understanding of the type of asthma we would associate with elevated IL-6. And actually there'll be a trial going on in the next year or two looking at IL-6 inhibition in asthma, actually a couple of trials. So I think those data will be quite interesting to help us really understand where IL-6 sits with regards to a biomarker armamentarium. So the last study that we'll talk about today is looking at 2 biomarkers we have available to us in practice, fractional exhaled nitric oxide, or FeNO, and peripheral blood eosinophil count. We already use a peripheral blood eosinophil count quite a bit. If you're using biomarkers, you're required to, but not all of us use FeNO on a regular basis. And that really has to do with a personal decision on whether to invest in this particular biomarker for your practice, because of course there's equipment to purchase, reimbursement issues are quite variable across the country, and so is it worth it? This study sought to test the hypothesis that peripheral blood eosinophil count and fractional exhaled nitric oxide, or FeNO, have additive and potentially discriminative value in predicting exacerbation risks, but also response to therapies by looking at studies of Mepolizumab and Dupilumab in this case. So the Mepolizumab trial evaluated 3 doses, and these are IV doses, so not doses we're using now, but I think still useful for proof of concept. These were doses studied earlier at 75, 250, or 750 milligrams every 4 weeks. And the Dupilumab trial also evaluated 2 doses, 200 and 300 milligrams sub-Q every 2 weeks for 52 weeks. And these were all patients who had eosinophilic asthma, at least 2 exacerbations in the previous year. And these participants were divided into subgroups based on their peripheral blood eosinophil count, so above or below 150 per microliter, and their FeNO levels, above and below 25 parts per billion. So 1,540 participants were evaluated, so in a robust data set. And what was interesting is, and not necessarily unexpected, but in those patients who had elevated peripheral blood eosinophils and elevated FeNO, had much higher exacerbations, but also improvements with either Mepolizumab or Dupilumab. So these 2 biomarkers together can predict or give you a sense of which patients are likely to have exacerbations, and then you can actually choose either biologic and see benefit. Now, when the groups were stratified to look at those who had low peripheral blood eosinophil counts and low exhaled nitric oxide levels, you can see that neither Dupilumab or Mepolizumab had a significant effect on exacerbations. And that's not surprising. The phase 3 Mepolizumab studies would suggest that those patients with less than 150 eosinophils didn't really respond particularly robustly. And the same is true for the phase 3 for Dupilumab. So that supports those phase 3 data. Now, interestingly, when you look at those patients who have low peripheral blood eosinophil counts and high FeNO, that group didn't do as well with Mepolizumab, so not unexpected, but actually had improvements with Dupilumab in exacerbations. And FeNO, as we know, is an IL-13-driven biomarker, so therefore it would make biologic sense that Dupilumab would potentially have benefit because it inhibits IL-13. I think these findings suggest that using both of these biomarkers in practice have additive value in not only predicting exacerbations, but who might respond to which biologic, since we have many to choose from at this time. In conclusion, there have been some amazing developments occurring for patients with uncontrolled persistent asthma, and they continue to occur at a rapid pace with recently approved and emerging targeted treatments. I think it's a wonderful time to be taking care of these patients as we have a lot to offer them. Many of the studies presented this year at ATS examined the long-term safety and efficacy of the currently available and emerging biologic agents and how biomarkers might help us predict exacerbation and treatment response. And I think as more targeted treatments continue to emerge, the care of patients with uncontrolled persistent asthma can be further personalized and outcomes can further improve. And we'll have more choices coming down the pipeline, as you heard today. And I certainly look forward to seeing more of this data emerge, and I'm sure you do too. Thank you very much.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GSV860. This activity is supported by an educational grant from Sanofi Genzyme and Regeneron Pharmaceuticals.